if we could welcome up, this is Professor Stevanovic, and Professor Goodman, Dr. Weiner, thank you. I don't know why I'm telling everyone's name because I can't pronounce anything. Habyarimana. Habyarimana. Does he? I just saw him outside. And then Professor Katz, I think, is going to follow up. She should be here in the next couple of minutes. Okay. So starting off with the Institute for Reproductive Health.
Bear with me. So good afternoon, everyone. So my name is Natacha Stevanovic-Fenn, and for the past decade, first I should say I'm a sociologist, so thank you, Niraj, for promoting our discipline. So for the past decade, I've been working on issues related to gender, sexual reproductive health, and violence and rights in developing regions. And I'm here today to speak on behalf of the Institute for Reproductive Health to highlight some of the key issues we work on. So I thought that I'd start with a story, and that's the story of Sarah, a 15-year-old girl living in Kinshasa in the Democratic Republic of Congo. And at school, a 19-year-old boy she really likes tells her that he's gonna give her a smartphone if she comes over to have some pastries with him. She does, and they have unprotected intercourse. A few months later, she realizes she's pregnant, and she can no longer hide it from her parents, who decide to take her out of school and to marry her to the boy. She now later has a child and has no chance to return to school. So we all know that Sarah's not alone. We have today an estimated 21 million girls aged 15 to 19 and 2 million girls under the age of 15 who become pregnant in developing regions. And most of these are unplanned and unwanted. Why Sarah's story? Well, this is at the heart of IRH's mission, which is to design and implement evidence-based programs to address these critical issues, to advance gender equality, but particularly as it relates to adolescent and sexual reproductive health. And so one of IRH's hallmarks is to translate scientific data into really practical guidance for programs that address issues of adolescence. And we're doing this right now under our currently USAID-funded project called Passages, which seeks to understand how social and gender norms influence adolescent reproductive health and gender-based violence in West and Central Africa. We've advanced understanding of social norms through our Learning Collaborative, which is a group of experts who work together to facilitate collaboration between a wide range of organizations and also individuals, experts working on adolescent and youth norm-shifting interventions. And together we look into what norms are, how to measure them, how they influence behavior, and most importantly, how to scale up effective normative interventions. And so in this effort, and with support from USAID and the Bill and Melinda Gates Foundation, we've developed a participatory tool called the Social Norms Exploration Tool, also known as the SNET, which is a really simple and cost-effective tool. So now, how do you use it? Well, say you're a program implementer who wants to address adolescent pregnancy in Sarah's community. The SNET would help you identify where and how to focus your program. And so a starting point would be first to identify the behaviors that are most important to achieve your intervention's objectives. And for Sarah, this could be, say, the absence of communication around sex and reproductive matters with her caregivers or parents, and access to SRH services. Second, it would help you identify which social norms drive those behavior. And third, which are the key people influencing these norms and behaviors. And this information is what helps make programs specific to the context, and it improves really their future success. So in the past decade, there's been a growing recognition that addressing social norms is critical to achieving gender equality in reproductive health. And here at IRH, we've been at the forefront of advancing this research agenda. And through really successful partnerships with donors, such as USAID, the Bill and Melinda Gates Foundation, Save the Children, UNICEF, and many others, as well as with implementing organizations and local partners, all of whom have been using our work and applying our work to inform their programs related to SRH. Now, to conclude, think about if we had just one generation of adolescents who were able to delay child birth until they are ready, to continue school and to have healthier children. Just imagine how a country could be transformed to one such generation, right? And this is what we at IRH are helping to achieve in order to sustain improvements in adolescent sexual reproductive health and prevent violence. Thank you so much.
There you go. That's it. No. Yeah. Good afternoon. My name is Lou Weiner. I'm a physician, medical oncologist. I direct the Georgetown Lombardi Comprehensive Cancer Center, which is one of 51 National Cancer Institute designated comprehensive cancer centers. Our vision statement for the Cancer Center includes the words local focus, global impact. So we've been thinking about this a lot. I don't know how I'm going to get under 3 minutes since it takes me that long to clear my throat. But, and Jeg, you didn't have to laugh when I said that. So anyway, we have a large number of activities related to global health. And as you can see here, we are really interested in exploring the intersection of cancer education, cancer research, and cancer care prevention and control needs in order to identify ways to improve health not only in the United States and in our catchment area of the DC region, but also around the world. The key challenges that we're trying to address in the global space are lack of clinical and research infrastructure that hinders the capacity to either educate and prevent cancer or to provide a relevant infrastructure for cancer care, a lack of trained scientists and clinicians in many parts of the world that becomes a rate-limiting determinant for care around the world, and a lack of evidence-based models for population-based cancer prevention, particularly when there aren't sufficient societal infrastructures in order to support that. Now, the context of the work has been that as an NCI-designated comprehensive cancer center, we depend in not insignificant part on National Cancer Institute funding and infrastructure to do our work. And since 2016, the enthusiasm of the federal government for supporting NCI global cancer efforts has declined substantially for reasons that are out of my control for sure. Nonetheless, Chris Loffredo, who is here and is actually one of the prime drivers of our global cancer efforts at Lombardi, and I are both on the NCI 2020 Annual Symposium on Global Cancer Research at the 2020 Consortium of Universities for Global Health Conference. And this is a big deal, and this has occupied an inordinate amount of time for both of us, but especially for Chris, in putting this together. So we're at the table, and that's a good thing. We have a number of activities in the area of cancer education. We participate in courses, lectures, and mentoring in global cancer disparities. And Lucille Adams-Campbell, who leads our efforts in minority health and health disparities research at Lombardi, and Chris Loffredo, Suzanne O'Neill, and Chirandeep Dash serve in our BS program in Biology of Global Health, the Master's program in Epidemiology, and the PhD in Global Infectious Diseases. So we're trying to be as engaged as we can in that area. We have a fair number of cancer research activities, and as enumerated here, Chris and Chirandeep, but especially Chris, have been really prime movers on looking at environmental risk factors for liver cancer and bladder cancers in both Egypt and Thailand. And Chris has been doing this work for, almost a quarter century now, right? Lucille has been studying cervical cancer epidemiology in West Africa. Diana Breathwaite, a relatively new recruit, focuses on lung and liver cancer screening in Guatemala. And Paula Cupertino, who's a relatively recent recruit of our consortium partner in New Jersey at Hackensack University Medical Center, studies tobacco control in Puerto Rico. We also are dipping our toe into the cancer care paradigm. This is really tricky business. primarily because training in people from overseas in United States-based hospitals requires licensure and other activities that make it devilishly difficult to provide people with the clinical training they need. And that'd be a great thing if we could figure out a way to make that work. But again, that requires discussions at a very political level, as you could imagine. But John Marshall, who's currently actually on sabbatical at Oxford, has developed this really extraordinary consortium of leading academic centers and pharmaceutical companies around the world to take a look at personalized cancer therapies, where by doing a very detailed molecular analyses of people's cancers, you can identify those rare mutations that can be treated by a particular drug that might be in development. And by breaking down the barriers between these companies, it's possible for anybody, anywhere, who has a cancer with one of these rare mutations that might be targeted with a drug to receive the drug under a general all-purpose protocol. And that is a huge step forward in trying to take people and giving them opportunities whether or not they live in a very fancy part of the world. And it also allows us to do really great work in the global health therapeutic arena, and it's something we're very excited about. Thank you very much.
Okay, great. Thanks, everybody, for having me here. I really appreciate it. I'm Jesse Goodman. I'm a clinician in infectious disease and public health person who's functioned at both the local and the global health level. And I like what Lou just said about that, acting locally and globally, or whatever the slogan was, because we're sort of doing both. And if there was ever, the major problem, we're focused on access and appropriate use of medical products throughout the world. And a major focus has been on antimicrobial resistance, which I started working in maybe when I first met John and entered the government, at first under Clinton and then Bush, and we made the first national plan on antimicrobial resistance. But, as everybody has heard in the media, sometimes in sensational terms, we do face the prospect of a world without effective antibiotics. And I see this whether across the street at our hospital here or, communing with colleagues from around the world. Particularly at a global health level, the challenges include resource constraints and competition for resources in these at-risk areas, and the fact that what I've termed a phrase for antimicrobial resistance is a slow emergency, where until it happens that we have widespread untreatable organisms, this seems quite abstract too, because for most clinicians and public health personnel, there still are antibiotics that work. But our lag time in developing new antibiotics is typically 10 to 20 years if we're lucky enough to have the incentives lined up and the science lined up and develop them, which is a whole other problem. So it's been really hard to get this on the map of the global community. Every country has plans, but they don't really have resources to implement them. And there's really absent surveillance of the problem. So what we've tried to do in this period of diminishing resources is to find ways to leverage existing data and resources and make a difference. One is to really go out and say, can we find data on some of the worst antimicrobial resistance threats in places where there have been gaps in data. So for example, in Africa, WHO reported only data from about either 7 or so out of 40-something countries, and we were able to find data out of the majority of countries in Africa and put it all together and publish it. And recently did something similar on Southeast Asia, which is shown here, and in that process illustrated to people that the two what I would describe as antibiotics of last resort, carbapenems and colistins or polymyxins, that we use to treat infections like E. coli and Klebsiella when they're resistant to other organisms, that genes that confer resistance to them are circulating in common in about 7 countries or so, which are shown on that map. In addition, we've engaged with practice and policymakers on the ground in a variety of ways. I mentioned a couple of examples. A group out of Hong Kong University is trying to look at how you should implement national programs in antimicrobial resistance, for example, in China. And we're working with them as the sort of U.S. representative to that. John here knows because he helped engage me in it, and some of the others here. We did a program trying to engage the faith-based community, and one of our new colleagues, Deus Bezerra, we were happy to include him in the most recent effort. And then to the local level, one of the first things that I did when I came to Georgetown, now about 4 years ago, was join with infectious disease nurses, physicians, pharmacist colleagues across the region in most of acute care to share data on resistance and share best practices. And that's a very active coalition we have called ROAR. And to Dr. Lafredo's comment and many others, there are great similarities between sections of what the challenges we deal with here and in less resourced countries. So one project we've done with the DC Health Department is looking at long-term care facilities in the District of Columbia, which are under tremendous financial pressure and yet also have to achieve high-quality health care in an under-financed environment. So we've worked with them to try to improve care and in infection prevention and in use of antibiotics in long-term care facilities. And then Paul Ropey mentioned that he and I are involved with fellows supported by the U.S. Pharmacopoeia, which advances medicines quality across the world. One of the challenges is we have substandard medicines around the world, and their use helps worsen the resistance problem. And we're involved in a study of how the WHO antimicrobial resistance action plans are being implemented in countries with respect to protecting medicines qualities. So those are just some examples, and I'm thrilled to be here and to work with any of you in any way we can. Thanks very much.
Okay. So my name is James Habyarimana. I'm a faculty at McCourt School of Public Policy. I am one of about 20 members of GUIDE. I had a slightly different color scheme, but I guess didn't work with Maeve. So let me explain what GUI squared DE stands for. It's the Georgetown University Initiative on Innovation, Development, and Evaluation. We are largely social scientists, like Natacha, so to Nerad's point, we're in the room. And the work we do in global health spans, I guess, kind of a wide arc. There are 3 groups. And the first thing, one of the things that we work on is to identify low-cost solutions to global health challenges. And we use a set of tools that are familiar to us as social scientists, so varying prices, information, social norms, to change the behavior of beneficiaries, providers, and other actors. And so that's kind of the first bucket. The second is measurement. I think we spend a lot of time trying to understand who provides medical services, because in some ways these are really important actors who mediate a lot of the amazing technologies and protocols that are developed. And ultimately, what do they know and what they do? This is not working as well as I wanted, but let's just put everything up on the slide, and then I'll explain this. And then of course the last thing is, in some ways we work to try and get the solutions that we develop to go to scale. And so we're really interested in identifying opportunities and impediments to taking successful solutions to scale. One of the things that we do at Georgetown, I think we try and exploit the amazing scholarship that we have here. And so we exploit some world-leading scholars in things like digital finance and try to connect that with how do you get mothers in rural Western Kenya who live quite far away from facilities but have access to cell phones. How do you get them to actually sort of deliver their babies in hospitals? And we're really pleased to welcome Dr. Jishnu Das from the World Bank, who's done some really important work in the measurement and quality of medical services around the world. And in particular, one of the things that Jishnu has been working on is understanding what physicians in a lot of these contexts do, and using that information. He can say a lot more about what he does, but using that information to design interventions to improve the treatment and management of certain illnesses. And so right up here, I have a slide on I guess a little picture that suggests that Jishnu has been doing some work in India, where he's been working with a wide range of informal health providers. So these are mostly actors who work in the private sector, who have very little medical training, and getting them up to speed to essentially improve the management of tuberculosis. And his work has actually led to the Indian government, more or less formalizing quacks. This is something that wasn't done before, but they're essentially kind of in a lot of places. And as we were in between in the coffee break, Jishnu said he's been doing some work in Kenya where he's randomized the law. But ultimately, one of the things that happens when physicians don't do what they're supposed to do is, in fact, that people, they misdiagnose and carry and make faulty prescriptions. But in fact, we have legal means to and regulation to try and actually sort of improve their practices. And he's been working in about 1,000 facilities, half of which are essentially kind of assigned to, in some ways, have much more strict enforcement of the law. And he discovers that, in fact, when clinicians are found to be making mistakes and they can be shut down, that in fact you can actually sort of improve the quality of medical services available to the population. And then finally, we also have a wide range of political scientists, and so Professor Nuruddin has been doing some work in Bihar, where we try and understand how political markets and bureaucratic incentives shape health systems. And ultimately, in some ways, the question ultimately is to understand sort of what are the priorities in these health systems and how can we actually sort of work with, in those contexts to improve and scale important solutions. Thank you very much.
Not nearly as tall as James. All right, thank you. So first, apologies for showing up just in time for the slide. Peter Hotez, who is a mentor and kind of hero in global health, was speaking on the very far side of campus. So we raced over here. And I direct the Center for Global Health Science and Security. I'm looking out into a room of people who pretty much know who we are and what we do. So I will give the elevator speech, but also delighted that you're all here and know who we are. We are currently a center of 5 full-time faculty, 5 full-time staff, plus a series of students and consultants and contractors, as well as a growing number of faculty affiliates from across the university that we are delighted to work with. Our current challenge, sorry, it's right in front of me. Thank you. So that's our mission statement, right? So the center analyzes policies and practice used throughout the world to prevent, detect, and respond to emerging health threats before they become international crises. So we are a group of multidisciplinary experts, but at the core we are a policy shop looking at how to help governments and institutions think about how to prevent, detect, and respond. You can see the list of focus areas. There's a bunch of different topics that we are interested in, that we spend a lot of time in. We currently, I believe, have 10 active awards that we're in the midst of, and sub-projects within that. So it's relatively diverse, and each of the faculty within the center have their own line of research that they focus on. I think to give the big picture, though, I'd like to think that we try to develop evidence in global health security, which is something that has not really occurred that much to date, and then try to translate that evidence for decision makers and the professional community. So we work on establishing new data, new sources of information. We have a series of online tools, including something we call GHI, which is the Georgetown Infectious Disease Atlas. We are trying to provide new contributions for governance. We have a new group that is looking at international law impact in infectious diseases. We are trying to assess new factors that are influencing the emergence of infectious diseases around the world, and particularly as the world changes in front of us due to things like conflict and climate change and evolving biotechnology. So I think we are, as the map that's somewhat hard to see shows, at last count, I believe we were in about 32 different countries, and engaging with ministries of health, but also agriculture, sometimes finance, sometimes security, and trying to translate the work that we're doing into a number of different fora. So looking at, we are heavily engaged in the Biological Weapons Convention and in presenting our work and again, the research we're doing there to influence those debates. We held a tabletop exercise at the Munich Security Conference last February looking at global governance. We work closely with the World Health Organization. We have faculty who are working with ASEAN, with the Global Health Security Agenda Consortium, as well as leading workshops and conferences for different parts of the US government, and then workshops with governments around the world to help identify and adapt new policies for enhancing health security. There we go.
So I'm actually going to speak for the Center for Global Health. I'm taller than Rebecca. For the Center for Global Health Practice and Impact. So this is one of our newest centers at Georgetown, and this is the team. And every single one of those people is out of the country today. So I'm just going to, I know a lot of you are already familiar with this work, but the Center for Global Health Practice and Impact combines the extensive field work implementation with large programs together with high-level policy development. And so their combined synergies make a very powerful combination reflected in their work. I'm just going to go. These are the strategic principles, but so in their first 6 months, the center's been already successful in obtaining grants awards. The most significant is a new grant they just received. It's a 5-year grant called the Transforming Data and Evidence into Impact, which is tied. And it's focused on HIV and other infectious diseases. It's given by the Centers for Disease Control and Prevention through funding from the PEPFAR program, which as one of the members of the center is Dr. Mark Dybel, who used to run the PEPFAR program. So this, and I'm only speaking about one of their grants and one of their work, but they, the funding is going to support country national goals in HIV and in 2 countries, one in Cameroon and the other in Haiti. And so I believe that most of the team is in Cameroon right now. And so that work is to support the UNAIDS 90-90-90 goals. So 90% of people being tested, 90% of those on treatment, and 90% of those reaching viral suppression. So obviously this is a big change for the university where there's a large implementation program that hasn't occurred previously, but it's also very exciting, and we have great leaders in that. And looking forward to another opportunity where someone from the center can actually be here and you could ask them specific questions. But I did want to at least mention them because they're a great new team, and if you see any of their smiling faces, I hope you will say hello to them. Before we get into Q&A from this session, I want to bring up 2 additional faculty members who were not able to join us earlier, and so and then we'll break into Q&A and finish off our day. So the first is Professor Mendenhall, who's going to speak about the STIA program at SFS.
Well, I thought I might follow Rebecca which, to shock everyone more, she even teaches for this program, so on top of everything else. Oh, how do I do this? What do I press? What button? Oh, this green button. Oh, this is it. Okay, great. So most of you probably know, since everyone in this room has been around for a while, STIA is an interdisciplinary program, the only program that's not safe from science in the School of Foreign Service. That's our little joke we love repeating. But where people come to really think critically about questions at the center of health and policy. We are the second biggest major in the School of Foreign Service and growing by the day, and we're hiring 2 more faculty members this year, which is exciting. One of 4 concentrations in the STIA program is global health. We have about 20 to 30 students each year focusing on global health. We think about global health problems from a critical, international, political way and try to really think about innovations around technology and development and also be reflexive of what these kind of work does in the world. And we think of everything from critical perspectives to international diplomacy and security. As you know, Professor Katz is part of this. We have a really exciting and innovative gateway course, which all of our majors take, but also all of our minors. We have a really exciting STIA minor that students across the college and take, and it's really fun, especially our biology of global health students and NHS students in global health who engage with us. This is one of my thesis students who I just thought this photo was fun. She worked with me in South Africa on some research a few years ago. I was actually gone, I missed the entire forum today because I was teaching our honors seminar, and we have about between 10 and 20 students every year who write really incredible honors theses, and it's really fun to tag along and mentor them. We have a really interdisciplinary faculty. Rebecca and I are the only global health people. We have a planetary scientist. We have people who study climate change and water and security and emerging technology. So our students are really coming to these questions from interdisciplinary perspectives and pushing boundaries. And we actually just got a really new, really exciting new donor who is funding our interdisciplinary research projects for our students. So our honors theses will get full funding with our new director, Joanna Lewis, which I have a little photo of. She didn't like the photo, but so excuse me for the photo. But our new director, Joanna Lewis, has brought in our first donor, so we're hoping to build the program and to promote faculty research across disciplines, really thinking at these questions, about these questions at the intersection of science, technology, and international affairs. And I think I've focused on that. We really engage, as many of the programs do here, across DC. We try to take advantage. We go to the zoo, we go to the Smithsonian more broadly, the National Museum of Natural History, and we also, most of my classes have a service learning component where our students are working in urban farms, volunteering at Martha's Table, getting a little bit of engaged experience in the larger community that is inclusive of this whole idea of global health. Well, I think that's all, so yeah.
Good afternoon, and apologies. I was also teaching this afternoon, so in the practice of global health, sprinted over here from the medical center to come in and give this talk on our master's program in biohazard threats and emerging infectious diseases. And I think just to focus on, I've heard multidisciplinary, interdisciplinary approaches throughout the course of, I think, every program and every center, and I think that just goes to show how science and technology, public health, global health security, really don't operate in vacuums anymore, and in order to train the next cadre of professionals, we're really working across a number of disciplines. So this master's program is based in the medical center, and one of the things that we really look at focusing on are how infectious diseases, whether they're naturally, accidental, or deliberate in occurrence, affect global health and affect health security. And how we train the next group of professionals in terms of thinking about how no matter what the source of the agent is and how the event occurs, there are both national and global disciplines and frameworks that apply and can be addressing these global health threats. In terms of program evolution, our program really began based on some of the national threats to health security and based on the Marathorax events in 2001, and has really evolved over time. The threats that posed, I think, the biggest risks to health security in the US have evolved. The technologies to advance countermeasures, vaccines, and research have evolved, and so we have really tried in our program to think about how to address both the threat of infectious disease and the types of technologies that are coming into play. Some of the constraints that we have is that threats evolve, diseases evolve. I always tell the students that they picked a great discipline to study. They have good job security and the fact that infectious diseases will always be an issue. But that allows us then to think about how we approach global health in terms of infectious disease threats, biodefense, both in terms of national and global strategies, the threat of bioterrorism, because we do have a health security aspect to our program, emerging technologies, and then their impacts in terms of dual use. One of the opportunities I think this program has in particular, it's one of only a handful of master's programs that focus on biological hazards and emerging infectious disease. We have a very niche program that attracts students from all over the country and actually all over the globe. We have, in an average of 20 students a year, at least 3 to 5 are international, which is fantastic. We have a fantastic resource of adjunct professors that are experts in the field, that work in the government, that work in the non-governmental organizations and even think tanks that come and lecture to our students and provide them not only on-the-job exposure of what they could be doing after graduation, but thinking about how the information is churning and turning and the priorities both from a domestic and international perspective. And we also have a fantastic network of alumni that have been exceptionally active in mentoring our current students. In terms of Georgetown's role, I mentioned we're just one of a handful of programs that actually offer a master's degree in biological threats. This is just a breakdown of the last 4 years of our students in graduating, where they were in the next, where they were within 6 months of graduation. So we've got about 50% of our graduates go into government and policy, focusing on emerging technologies and biological threats. There are a number of U.S. agencies that focus on that in particular. We also have a number of students that go into graduate degrees in the last 3 years, MD, PhD, and JDs. Business, biopharma are also polls for our program, as well as consulting and healthcare. So I think we are able to train a group of individuals that really can cross disciplines because of our faculty, because of our topics that we instruct, and we've had some great interactions with faculty within the medical center and on main campus. So thank you.
To anyone who wants to look at their schedule, this session was supposed to end at 4:45. It is exactly 4:45. That is some sort of miraculous thing. Sorry, that was really exciting for me. I do want to open it up for questions. I think that we had a lot of really interesting conversations, both at the coffee, but questions for our panel about, sort of the research work at Georgetown, either specifically or as we look across Georgetown of our research. And then we can sort of talk maybe later just more broadly about the breadth of global health work. Yeah.
Hi, thank you, Maeve. Felice Apter. I'd like to go back to the beginning and the Institute for Reproductive Health. And I know you had a very limited time, but I'm really curious in terms of the lovely connection that Georgetown has to the faith community and engaging in other countries, especially on very sensitive topics and gender dynamics. To what extent does your program focus on engaging with males and the role of males instead of kind of a female focus? So if you could talk a little bit about that, it would be great.
I think I can answer that because I worked directly in male engagement. So you have the right person right in front of you, and so we do. So we work. I can't speak for all the projects and all the topics that we work on, but so I can give the example of the male engagement that I'm currently working on, which is right now in Togo, and this is directly involving men and boys, particularly men, and also faith leaders. Sorry. To make them aware of the importance of being part of the health and the sexual reproductive health of not only his partner, but also for himself and his children. And so through this program, and this is USAID funded, this is breakthrough research, and so one of the activities is around couple counseling. And I just finished the assessment of this intervention, and it was really interesting to see. I mean, we had this was qualitative work, so with a very, very small sample, so not super rigorous, but at least it gives us some ideas of how we can refine some of the tools that have been used or activities for the intervention, and it shows that men have been really interested in being part of discussions related to sexual reproductive health, but also to know more about what are the choices and what are the methods that are out there that can be used. And also they want to be involved also, with raising children, but there's always the problem of, when you do couple counseling, well, the men are in the field at that time. So there is really, really high demand for, for being engaged at that level. So I can speak more about this later after, if you'd like.
So all of the research programs have international footprints working in various countries. And the question I have really is well, number one, is there any overlap where you take advantage of the fact that two of you happen to be in the same place? Is there opportunity there, or is it something, and I don't want to prejudge the answer, is there actually an advantage to try and facilitate that as a university, or is it better that each group has its own location to work in and doesn't have to worry about what anyone else is trying to do?
Is this?
Yes.
So let me take a crack at this, because I think we've already collaborated with Deos's group in Nairobi. And so my sense is, I think the short answer to your question is, at least as far as we're concerned at GUIDE, we welcome any collaboration. As I think everybody in the room understands, I think there are technological solutions, there are solutions that have to do with behavior change, and combining those things for us is, I think, much more powerful. So we welcome the opportunity to work with anybody who's working in the areas where we're working. We have an office in Nairobi that is, a useful platform for folks working in that area. But we certainly work in other countries, in India, in Rwanda, Uganda, Tanzania, Zambia, and so on. So.
And maybe it's a question of whether the structures, you feel like the structures and relationships are in place to make that collaboration possible. Please, Chris.
Hi, Chris Lafredo again from Georgetown. I have a question for James. You mentioned the informal healthcare sector, which is a euphemism that covers all kinds of people like midwives, a trusted elder woman in a village who gives health advice, off-duty nurses who give injections with needles that haven't been properly cleaned and sterilized and spread infectious diseases. On the one hand, we might say, oh, this is a very difficult situation. From a policy point of view, this should be shut down. I mean, that's one thought. But on the other side, these are trusted and valued by the community, and they provide very important things that people otherwise wouldn't get. From a policy point of view, what are some of your thoughts on how you engage with such persons? Because typically they're not organized, and there's not a union, and there's not a professional society. And how do you find them? How do you engage with them? Is that a community level thing or a top-down thing?
Okay, so this is a difficult question, and the expert is actually right behind you. So in some ways, I think I should. The second half of my answer will be to hand off to Jishnu to explain, I guess, how you from a policy perspective, what is the best way to deal with this. I think you're right. It's certainly not feasible to shut down and in some ways regulate all of these folks out of the market. It's for many people, that is the only healthcare service they can get. In Western Kenya, we did some work trying to get more mothers to deliver in facilities, and it became very clear that some of the people who are really important in sort of shaping the decision about where you deliver is actually, in fact, the essentially kind of the local traditional birth attendant. Who is paid a price and so on. So if you want somebody to go from the village to a facility, in some ways she's an important mediator. And we have had some success actually working with them to refer women to facilities. It did require us, playing with, incentives and providing incentives to the traditional birth attendant to make this referral. But I do think that in some countries, there is some organization. Jishnu can speak to this. But in many places, I think you're right. You have to, in some ways, go and find them. Jishnu?
I think, so as an economist, you always start off by thinking, what's the data I can bring to the problem? And the way I think about the data was twofold. I mean, one is what access do people have to what kind of care? And the second is, how does that market work in the sense, if there's a caveat emptor, and then how big is the caveat, right? So we've spent a lot of time just measuring these things. And it turns out, so about 80% of the primary care in India is provided by people without medical training. They exist outside the law, so 80% of our care is provided by those who don't exist, which is, a difficult situation. They have very strong associations. Every one of them is in some kind of association. So what happens is at the local level, they're all embedded in the medical system, in the formal medical system. They'll have regular meetings with the district headquarters. They'll have referral chains going up and down between doctors. They go to doctors' clinics to get trained and stay there for 3 years. And then the most interesting part is that the quality of care they deliver is kind of similar to what they get in the public health center. So objectively, it doesn't seem like there is a big gap between what poor people get when they go to the primary healthcare center or when they go to the local guy who doesn't have formal medical training, but is probably 8 to 10 years of kind of craft-based informal training when he or she was the compounder, the guy who mixes the medicine in the formal doctor's clinic, and who has an established referral chain with all the hospitals in the area, right? So I think a lot of the thing that we're trying to do is just say, can we put some numbers on the table? Can we put some basic data on the table that kind of questions the assumptions behind the things that we are doing? Then that's it.
Okay. Oh, yeah, please.
Is this on?
It is.
No, I was just going to comment that there's a series of interesting similar issues around antibiotics and how they're used, and that, there are often self-medicated or through informal practitioners where people don't have access to reasonable primary care. So, people who don't need antibiotics can get them easily. They also don't have access to high-quality medicine, so you can go to an informal market, or people will walk down the roads with backpacks full of antibiotics, selling something that might be $2 in the pharmacy for 10 cents for 3 pills. And, so there are, the two dynamics are access to reasonable care that might have diagnostics associated with it, and then access to trained practitioners. And I think in many cases, governments use these informal systems as a way of not having to invest or provide in care and medicines, But you can work with, you can do what you can also with parts of those informal systems to do more education and potentially improve how prescribing is done. but that may not align with the economic incentive, which is, simply to sell more medicine. So I think this is an area where policy and practice and solutions all intertwine, but it's quite disturbing because one hand, people who need antibiotics and medical treatment can't get it. On the other hand, people who don't need it can get it.
And this sort of reminds me of an announcement I should have made earlier in the afternoon, which is John mentioned earlier that we have global health fellows, but we also have global health faculty grants. And so they are collaborative seed grants for faculty members who have projects or work they want to do across the university, engaging colleagues sort of at a different part of the university. So I will send out more information about the very easy application process. But we do give out $70,000 of grants every semester to faculty members, and the deadline is coming up next week. So please don't forget that this is a great opportunity, and especially something you might want to chat about afterwards as you find your cohort in crime to work on a project together. That would be wonderful. Yeah, one final question.
Thank you for a great panel. So I want to draw on that point of act local and think global. Local is DC and Georgetown, but it's also the United States. And in global health, we're always trying to get someone else to do something, whether it's a government to introduce a policy or communities to act in a certain way. But there's a lot to be said for emulation. And for example, if you look at Brazil and South Africa, cesarean section rates are 80 to 95% in private healthcare because it was emulating this Western, new, scientifically advanced way of delivery that was safe. And I wonder how much work is being done on influencing policy in the United States that can be emulated around the world for better health outcomes. And the thing that comes to mind immediately is regulation of the food and beverage industry, for example, that can be emulated around the world. There's antibiotic practices as well, and agricultural use of antibiotics that can also tackle the AMR issue.
Do you want to speak directly to that?
Well, on antibiotics, I think that's great. I would put it two ways. One is emulating. There are things that we can do to clean up our act that are relevant to everyone. I think we're not necessarily always better. So, it's not just emulating, but I think developing and sharing best practices. And frankly, I wouldn't presume to work with some of the people I've partnered with in other countries if I hadn't done this similar work here and if I didn't know the content. So, it's not just bringing knowledge, it's bringing practice, experience, and hearing what are the unique challenges, which might be the same as here or they might be different. So I totally agree with that. And I also often, this ties to some of the cross-cultural questions raised. I have students come to me and say, I'm interested in global health. I want to go work somewhere. I say, well, if you're interested in HIV, the seroprevalence in DC is as bad as anywhere in the world. And, you can help solve our problems here. And, so I think we need much more of this kind of mentality. And, I meant to say the genes and organisms that cause drug resistance or influenza that Bruce Skellen and I worked on together in HHS, these are not things in one country or another. These are global problems. And the science and the social science, I think, are global.
So I just wanted to reflect on that in a slightly different way. In D.C., a black woman with breast cancer has about a 30% worse outcome than a white woman with breast cancer. And the parochial view would be that we should learn how to take care of people in D.C. and then use that to perhaps influence how treatment may work better overseas. And I would imagine that we probably have a lot we can learn from our colleagues around the world and then try and apply it here in our particular cultural context. And so one of the things that I would like to see happen for us at the Cancer Center would be a way to link with global health experts who might be able to share with us what they consider to be best practices. And those best practices aren't necessarily going to be, what antibiotic to use, what chemotherapy drug to use, but rather how do you make sure that people get screened? How do you make sure that people are actually acting upon potentially worrisome information about a positive test or a worrisome symptom? Because in DC, the major cause of poor outcomes that I was mentioning in breast cancer is the lag time between the abnormal mammography and the time the person can access the healthcare system. And presumably those are not medical problems, those are social problems.
Okay, well, okay. One more question and then I think we'll turn it to Dr.
Hi, my name is Gayatri. I'm a PhD student here, and I actually had a question for, I forgot her name, but she's the one that did the adolescent birth outcomes research. I was just wondering, is there any work that you're doing locally on postpartum mortality, and is there any way that Georgetown's being involved in that right now?
I mean, speaking for the Institute for Reproductive Health, we don't work locally. Mm-hmm. Yeah, definitely something that we should be more involved in.
John, yes.
I want to make a pitch for an idea that Maeve raised earlier in the day, which is one of the new projects, if you will, for this current academic year, is in the spring to organize what we're calling a global learning exchange. So the idea is to take an issue where people from the United States and maybe other countries, a common issue, which could be one that has a biomedical component, but also social and legal or policy environment, and have just an exchange of experiences. What has worked, what hasn't in different countries where the U.S. is where we're at the table. Our experience here is there to learn, but maybe to share, but more to learn. And so I think one thing our community could do is identify issues that would be ripe for that kind of experience. I mean, a number of them came up here, but really it's almost limitless, as we know. So I just thought it'd be my pitch, is we would love ideas, and it would be terrific. Mm-hmm.
We'll certainly follow up with Lombardi on that. Okay.
Well, it's great to end a conference with an idea for the next session. What a great afternoon. I just want to say, I guess, 3 thank yous, and make it brief so we can go outside and have some more sharing. First of all, to the panelists, those that are here and those that spoke earlier today. Terrific job in boiling down the work you do. I don't think we had to put up the end once, as far as I know. I think we wondered, which is really, I was watching, I don't think that ever happened, which I won't name any names. It's pretty unusual for some people on the panel, but in a good way, though. Always have a lot of good information to say, and really is hard, very hard to boil it down into a short amount of time. So congratulations and to all who did that. And really thank you to all of you and those who were here earlier today. What a really engaged audience and group of faculty, as you always are, but really made a difference today, was really helpful. And then finally, thanks to Maeve and her team. I know there are others who really put this together. I don't know who else is out there, but thank you, because it went well and we were organized well and we stopped it right at 4:45 and so on. So it's all good, but really much appreciated. A lot of good work to do in the future, a lot of collaboration and some discussions are going on, particularly also focus on our education programs in global health. I think there's some interesting discussions we can have along those lines and follow up on a bunch of other things. So thank you very much. Have a good evening.